My name's Jan Gregson. I'm a geriatrician and I work in Wanganui. The first talk this morning was meant to be given by Dr. Kirsten Holst, who's a geriatrician in Palmerston North. Unfortunately, for family health reasons, she couldn't make it, but I do want to acknowledge that she actually did most of the work on the slides and I just added a few bits here and there. Anything that's in blue is a direct quote from Kirsten. But I have to say, as I read through them, the sort of empathy was leaking out of me, and I'm maybe not the world's most empathetic person. But I could actually resonate a lot with what she was saying. And she made this comment that, you know, I guess I'm not an expert in the area of prescribing for PD, but there's a huge population of people with it in Levin that I inherited from a retired colleague. So, you know, Kirsten didn't necessarily want an interest in Parkinson's disease, but that's where she happened to be and that's what happened to be there. And I guess a similar thing happened to me when I first moved. I have an interest in stroke, but when I moved to Wanganui, I was the sole geriatrician, and in fact still am. I'm not supposed to be, but one of my colleagues recently retired as well. And there was this little cohort of Parkinson's disease patients that I sort of inherited and then acquired a few more along the way. And then there's an even rarer little cohort of the people who have the other movement disorders who are, you know, extraordinarily difficult. And I certainly don't pretend to be a particular expert, but I guess I've had to learn. Just to say, you know, when you do listen to David Bourke and the ladies from the Parkinson Society, I apologise, I forgot to introduce you, but thank you so much for coming. You know, when you hear the experts, you'll certainly realise that I'm not an expert, and you'll hear Terry, who's an expert at what he does as well. But sometimes you just have to get on with it and you have to learn. And I think one thing I've learned about these patients is and with the greatest of respect to GPs and other primary care health professionals, when you don't see very many of them, it is harder. So having someone, even if it's me, who takes some ownership of the little group of patients and learns a bit more can be quite helpful. When you hear the experts talk, you know, they will be saying some of the things that I'm going to say, and I'm making no apologies for that. There are some things that are worth hearing more than once, and you're hearing it from very different perspectives. Movement disorders, being progressive, have sort of distinct phases. There's the early bit where whatever you do seems to work and it all goes okay, and then there's a middle bit where there's a lot of fiddling about with stuff, and that's what I do, and then there's a later bit, and you know, the distinct issues associated with the stages require different expertise, even though it's the same diagnosis. So this, you know, again, I hope this is something you've all seen before. If you haven't read this paper, go and read it. 1817, still worth reading. So James Parkinson was an English surgeon, and he wrote this paper called An Essay on Shaking Palsy, and it's basically an observational study of a small group of patients that he was involved with, and he encapsulated most of what we still know as the syndrome that bears his name. And for once it's not a German pathologist that's got an eponymous syndrome. And what did he say? Well, he talked about involuntary tremulous motion, lessened muscular power, a propensity to bend the trunk forwards, and a propensity to pass from a walking to a running pace. And if you observe someone with Parkinson's disease, he was right, wasn't he? You know, that's why it's named after him. He didn't get it 100% right, because what he also said was that the senses and intellects are uninjured. And we now know that that's not true. Maybe in 1817, people with Parkinson's didn't really live long enough to get the later complications. But in fact, you know, we see obviously a lot of the senses and intellects being injured as time goes by. So what does the modern literature say? Yes, it's a busy slide, I apologise. As Merrin said, you will get it emailed to you. So, well, this is from Up to Date, which many of you may use. It's an American database. It's very helpful. I find, and they collate information from a lot of studies and editorials and things. There are other databases that are available as well, but this is the one the hospital I work at subscribes to, and I use it a lot. It is a progressive neurodegenerative disease. It gets worse. No matter what you do, it gets worse. It's not all that common. Hence, you know, as a GP over a working lifetime, you may not see that many cases of Parkinson's disease. And it's one of the instances, as I said before, where it is useful to have some degree of specialism where people see more. Because the more you see of it, the more you understand it. And that's just how it is, really. It is uncommon in younger people. I think, and this is a personal opinion, I think younger patients with Parkinson's do get a lot of attention. I'm not saying they shouldn't, but, you know, we're all aware that there are, you know, perhaps people in the media, celebrities who've had young onset Parkinson's disease, and I think it can give a slightly skewed perception of what this syndrome is. But in fact, and they often have more severe disease, which is of course unfortunate, but it is uncommon in younger people. But the incidence rises as you get older, and the average age of diagnosis is about 71. It's no longer the death sentence that it maybe used to be. People can now live for many years with Parkinson's disease, but it will progress. It has traditionally, for a long time after Parkinson, it was considered as simply a movement disorder or a motor disease. And, you know, yes, those maybe are the most obvious recognisable symptoms and signs. But we now know it's a much, much more complex disorder, and it is a syndrome. And there are people who are at the end of the syndrome where it progresses very slowly and they may have relatively few symptoms and signs. And there are people, again, often younger people, who have more severe disease where they have a lot of issues early and it progresses very fast. It is extremely diverse. I look after a number of patients with Parkinson's disease, and no two are alike. They have lots of commonalities, but there's no two that are the same. So we know that there are the, you know, non-motor manifestations, and there are the what you might call neuropsychiatric manifestations. And there isn't a test. There's no test. You know, people come to see me and they're always terribly disappointed that they're not going to get millions of blood tests and scans, but it is still a clinical diagnosis. There is some role for functional scanning to differentiate between Parkinson's and the other syndromes, but still, you know, that's not commonly available. It's certainly not available in Wanganui. So what happens? Well, we know that for some reason or another, the brain stops producing as much dopamine as it should do. And the clinical picture, as it presents, is dictated by the variable degree to which different bits of the brain are affected by that. Does anyone know how we know this? How we know that it's a dopamine loss issue? Terry, do you know?
I did, but I'm not saying.
Oh, okay. Clever boy. Yeah, years ago, apparently in California, there was a sort of designer drug that was created, you know, not a medical drug, a street drug as it were, called MPTP. And people would take it for whatever its pleasurable benefits were supposed to be. But a number of them developed Parkinsonian type symptoms and signs. And when they died and studies were done of their brains, it was determined that the drug had killed off this area of the brain called the substantia nigra, and so they were not producing dopamine. So there are other studies, of course, but that one always stuck in my mind because of just the interestingness of it, I guess. So, what are the clinical features of Parkinson's? Well, you know, James Parkinson told us, didn't he? There's a tremor. There's this concept of rigidity. Rigidity is an interesting phenomenon. Patients really struggle with it. You know, I often say to patients, do your muscles feel stiff? And they'll start talking about their stiff joints. And it's really hard to say, no, I don't mean your knee. You know, does your forearm ever feel stiff, or do you feel that your muscles are tight or don't move? And it's something they rarely, in my experience, complain of, and it's more of a sign. We find it. They don't tend to notice it so much. Bradykinesia is slightly misnamed. Obviously, this is a Greek term meaning slowness of movement, and there is slowness of movement. But one of the key issues with Parkinsonism is that people have difficulty overcoming inertia. And inertia works both ways. And again, James Parkinson told us this. It isn't just that they're slow to get moving or they find it hard to get moving. They actually find it hard to stop as well. And the other thing is, with inertia, of course, it's about change in direction. So people with Parkinson's, they may not volunteer it, but if you ask the right trigger questions, you know, do you bump into doorways as you go through them? Do you find difficulty turning corners? And they often do. So it's, you know, any change of direction, change of speed. It isn't just about being slow. And coupled with that, somewhat cruelly, is postural instability. So if you imagine you're not really good at turning corners and you lose your balance, the risk of falls can be quite high in these patients. Festination is a lovely word. I love that word. This is the shuffling gait that we often hear attributed. Yeah, so the steps get smaller, and coupled with the getting faster, there is this sense that people start to tip forward, and again, you know, the posture is quite unstable. The forward flex posture, again, this is a lovely word. People can develop a complication called camptocormia, and it's to do with the muscle rigidity. They don't just get arm and leg muscle rigidity, they get trunk and spinal muscle rigidity, and it produces this sort of characteristic hunching that we see. One that's often overlooked, and it is muscular, it is motor. People with Parkinson's get speech problems and swallowing problems, and in extreme cases, you know, I've met people who struggle to even swallow their own saliva. And often what that results in is that saliva spills out of the mouth. And in times gone past, and you know, I can remember textbooks used to say that one of the features of Parkinson's disease was hypersalivation. That's actually not true. People with Parkinson's do not produce more saliva, they just can't manage it as well, they can't swallow it as well. And speech disturbances, which, you know, can be very embarrassing for people. A very common speech disturbance is dysphonia, so they get, which is an issue with the volume of the voice, so people find that they become very softly spoken. And that has lots of social implications. You know, people can become withdrawn because if they go out with a group of friends, they can't actually be heard. And so they stop going out with their friends. So, you know, speech is a huge part of our lives. The mask-like expression, again, you know, typically we talk about the Parkinsonian facies, so the face just isn't as mobile as it was. And that's often misinterpreted, again, as disinterest or depression. And if you talk to people with Parkinson's, it is something that's really, we just think, oh, you know, your face doesn't move very much. But to them it's a big deal because people think they're miserable when they're not. Or they think they're uninterested. And the micrographia, it's a fairly characteristic finding where people will describe that their handwriting has changed, and typically it's got smaller. And it can get smaller in the time it takes them to write one short sentence. So it's a good thing to actually ask people to do when you're examining them. I'm not going to dwell on this too much because I know that Terry is definitely going to give us a fascinating insight of the later stages with cognitive disturbance and behavioural disturbance. But again, a busy slide, no apologies, you know, multifactorial complex syndrome. People can have, you know, any or most of all these things. And one of the most fascinating things is that, unfortunately, some of these are also side effects of the treatments, which creates tremendous challenges because when a patient's sat in front of you, it can be very difficult to work out, is this the disease progressing or is this something I've done to them by what I've given them? So, you know, again, really quite profound and florid symptoms at times. And then there are these other symptoms that, you know, don't really seem to fit together, but just represent, again, that different bits of the brain being affected by the loss of dopamine. A very common feature of Parkinson's disease, which Parkinson didn't pick up, is the phenomenon of anosmia, or loss of the sense of smell. And unlike many of the other sensory changes, it can happen very early, and it can happen before any of the other symptoms, and it can happen many years before any of the other symptoms. So there are reports of, you know, people who lose their sense of smell 10, 15 years before they get any other features of Parkinson's. That's not to say everyone who loses their sense of smell is doomed, because there are other reasons. I have a dreadful sense of smell because I have sinus disease, I hope, and not Parkinson's. I do have sinus disease, but I hope I don't have Parkinson's. And another fascinating one is this REM sleep disorder. Now, as we all know, when we sleep, there are stages of sleep, and when you reach REM sleep, you dream. And physiologically, when you are dreaming, your body is disconnected from your brain, and you actually become paralysed. So you don't move much when you're dreaming, normally. What happens in REM sleep disorder is that disconnect doesn't happen, and people literally act out their dreams. And you often may not get a clear history from the person themselves, but it's always useful to ask the question, however personal it seems: do you sleep with anybody? And if they have a spouse or a partner or whatever, they will often tell you, yes, they do. They thrash about in the night. They hit me, they punch me, they kick me. Occasionally people will tell you they wake up with bruises they don't know how they've got, but usually it tends to be a corroborative history that picks up the REM sleep disorder. The autonomic dysfunctions are quite interesting. I recently, for the first time ever, had a patient complain to me about oily skin. And I genuinely, up to that point, did not know that this was a feature of Parkinson's disease until I went away and read about it and looked it up. And unfortunately, it's extremely difficult to treat. You know, you just have to wear a lot of deodorant, basically. There are oral drugs, but they tend to cause more harm than good. But yeah, that's you know, not a common autonomic disturbance, but it happens. Temperature dysregulation is quite common. I certainly see a lot of Parkinson's patients. If they're inpatients, the nurses get very stressed because they're hypothermic. And usually they're completely asymptomatic with it, and it's just an observation. Postural hypotension is very common, and you know, can be quite difficult to manage, can be devastating to patients. They just feel terrible, they're dizzy, they black out, they fall over, they break things. So back to my wise colleague Kirsten from Palmerston. What did she say? Well, treating PD is often easy in the first 7 years. Everything tends to work, and after that you get into trouble. I would absolutely agree with that. In the early stages, the Parkinson's tends to respond extremely well to whatever treatment you give them, and I'm not going to go into treatment in great depth because I know David Bourke's going to do that. And often at this point, I do discharge people and don't follow them up, because I know that for a few years they're going to go away and they're going to be okay. And then I expect that they'll come back to me, and they do. It is difficult when you're talking to patients because, as I touched on before, you know, we know what rigidity is, they don't. And they often find it difficult to describe what they're feeling. And so we, you know, do need to try and develop the skill to ask them the right trigger questions. Do you have particularly vivid dreams and nightmares? Are you aware of thrashing about in your sleep? Does your wife ever say that you kick her in your sleep? That sort of thing. And I've already touched on this, you know, because the adverse effects of some of the treatments are the same as the condition, it can get quite tricky. People do get extraordinarily attached to their medication. It's very, very hard to persuade people that sometimes they actually need to be on less treatment than more. The most extreme case I've seen of this was a lady who went to extraordinary lengths to get additional dopaminergic medication. She would present to different EDs and tell them that she'd lost her medication or lost her script, and she would just effectively hoard Madapar and was taking it in, really ridiculously high doses. She was extremely dyskinetic. She would fall over because she was so dyskinetic. And I ended up admitting this lady simply to get some control over her medication. And we managed to get her down to, a reasonable dose of dopamine, and she was much, much better, but consistently said she felt worse. Objectively, everything was better. She was independent, she was functional, she was mobile, but she just insisted that she felt dreadful. And it was so extreme that when she went home again, we had to arrange a system where her family could lock her medication away, and we had to put a system in place that only one person could prescribe her medication and one pharmacy could dispense it. Otherwise, she'd have been right back to square one. And, so people, they like the way dopamine makes them feel. You're all very quiet. You're all ignoring my comments that you've got to join in. Tell me about your cases. I'm going to tell you about one of mine. I try not to have heart sync patients. I try and remember that my patients are people and that they're real and they have feelings and they get hurt and all the rest of it. So this man isn't a heart sync patient, but when his name is on the clinic list, I do sort of go, ooh. So Mr. J is a 79-year-old man. He is a fairly typical Parkinson's disease patient. He was diagnosed 8 years ago at the average age of 71. Like many people of his age, he doesn't only have Parkinson's disease, he's also got a background of atrial fibrillation. And at the time he was referred to me, his honeymoon period was coming to an end. He was 8 years into the condition. He's on a relatively modest dose of Madapar. At some point he's been given benztropine, which is one of the adjuncts. Again, David Bourke will talk in detail. And because he's in AF, he's on dabigatran. And I actually didn't meet him at this stage. He presented to ED with a fairly classical history suggestive of postural hypotension. He was dizzy every time he stood up, and he had 2 episodes where he'd actually blacked out and fallen to the floor, which is always a concern when people are on formal anticoagulation. Falls and, blood thinners don't tend to mix very well. And he had postural hypotension, quite marked postural hypotension. And interestingly, as is often the case in older people, he did not have a heart rate response to the fact that his blood pressure was dropping, which is why they fall over. So he was admitted to the medical ward under the care of one of my physician colleagues. He was advised to increase his oral fluid intake, and his fluid balance was monitored for a couple of days, and he was advised to add some salt to his food. He was provided with compression stockings. We must always be mindful. Doctors love charting things, don't we? But we must always be mindful there are other ways to manage things than drugs, except for compression stockings, which don't work. Does anyone know why? Because nobody will wear them. Yeah. They're hideous. Yeah. They're horrible, yeah. He didn't wear his compression stockings. They do work, if you can make people wear them. But they don't. And quite appropriately, my colleague said, well, let's see if we can get him off the benztropine. So his benztropine was stopped. Now, with hindsight, it perhaps could have been weaned, but it was stopped. And he was also started on a small dose of fludrocortisone. And over 72 hours, his symptoms, I didn't notice that, sorry, his symptoms improved. And look, objectively things have got better as well. He's still got a postural drop, but, you can probably tolerate 97 better than 64 or whatever it was, and he was feeling better. And he went home, at which point my colleague said, will you follow him up? And I went, yes, of course. So I saw him in clinic 4 weeks later. He was still getting a little bit of dizziness, but he'd not had any further loss of consciousness and no falls. Phew. But he's put himself back on his benztropine because as he said, and I have no way to disprove or prove this, he just felt dreadful off it. He felt that all his symptoms of Parkinson's disease had got worse, and he said he simply could not function. And yet, when I asked him, he was totally independent. He was independent, getting on and off chairs, in and out of bed, walking around. He could shower himself, dress himself, he could go shopping, he could drive the car. All the sort of parameters that, to me, objectively suggested his Parkinson's disease is well controlled were good. But he was adamant that he just felt dreadful without the medication. And when I checked his blood pressure, it was pretty much back to being not great. But there was no way this man was going to come off benztropine. I tried to talk to him about weaning it, reducing it. No, not happening. So after some discussion with him, I suggested that we added in some midodrine. So midodrine is a vasoconstrictor, and in my experience, admittedly relatively limited, it's very effective for people with Parkinson's-induced postural hypotension, or even drug-induced postural hypotension. And off he went, and he came back 6 weeks later, and he said he felt much better. He had had no further dizziness. He'd not had any loss of consciousness. He'd not had any falls. And his blood pressure was better. Jan, happy. Patient, really, really unhappy. I was saying, but you've just told me you're better. You know, everything's better. You're functioning. Things are great. You feel better. What? And this is a common thing I hear in geriatric medicine. This guy was ropeable, that in his mind he was getting a tablet to treat a tablet. He was only having to take the midodrine because he was on the other tablets. And he wants to come off the midodrine. You know, I was like staggered. I spent about an hour and a half with this man over the next couple of days. Kept bringing him back to various places to talk to him again. I offered him another opinion from a colleague. He didn't want that. And all I can say is I just said to him, look, you know, it is up to you. You are an adult. At this point, still a competent adult. I didn't say that, but he was. He was. He was definitely a competent adult. And I said, look, all I can do is give you the information, and you need to reach your own conclusions. And I was absolutely open about the fact that he might be on a tablet to treat a tablet. And sometimes that is what we have to do. We try and avoid it. But if he wants to take the benztropine and he wants to not feel lousy all the time, the midodrine is a solution. I was surprised he didn't want to know another opinion, because he really did not seem to like me at this point. But he didn't, and off he went. And I offered him another appointment, and he didn't turn up. So maybe he didn't like me after all. We have since re-met. He was re-referred and he did come. And he's actually doing extremely well. So, again, back to wise Kirsten. What does she say about this? Well, they have often managed their medications independently. Autonomy is brilliant. I love giving patients autonomy and saying, by all means, you know, twiddle with your dose of whatever and see how it goes. And, you know, not to overgeneralise, patients with Parkinson's disease in the main do that extremely well, but there's always odd ones where it can, you know, be a little bit problematic. I've recently taken over the care of a somewhat younger patient with Parkinson's disease. He's in his late 50s. And when he was given some autonomy to play a little bit with his medication, he racked it up to levels that were unbelievable. Again, you know, they like how they feel on it. So, you know, as a geriatrician, as a neurologist, David may say the same, you can't change these people's medications or give them carte blanche to change their own and not follow up. And we're in the middle phase now. The honeymoon period's over. We're in the middle bit, and this is where there's a lot of twiddling or fiddling, and you're constantly upping things, downing things, adding a bit in here, adding a bit in there. And again, I think, you know, I'm sure there are GPs who are absolutely great at this, my experience is that most GPs, when I talk to them, will say, we don't see enough patients with Parkinson's over our career to be confident to do this twiddling. So that's where we come in. Again, dopamine is important in reward systems. They love it. They, asking people to reduce their medication or even come off it is extremely, extremely difficult. And it comes back to what I said before, that sometimes you need to think about weaning it rather than just, stopping it. As the condition progresses and you get the issues with cognitive decline, and if they have it long enough, they will get it, it becomes very difficult because you're not just twiddling with the medication, you're having to manage that person's perhaps failing understanding of their medication. They may not remember whether they've taken their medication and take it again, or they may not remember and not take it. So, we have to look at all the mechanisms that are at our disposal to support people to continue to be as independent as possible, but have some degree of oversight. And it very much stops being just a movement disorder. This is one of Kirsten's patients that she told me about. Perhaps a bit less typical than Mr. J, but certainly who we see. And this was a man that she inherited from a neurologist when he turned 65. Now, maybe not all neurologists work the same, but in Palmerston North, apparently, when people hit 65, they don't see a neurologist anymore, they see a geriatrician. So this was the process, and she didn't really have any choice. And the thing is, I've inherited a couple of patients like this as well, and you do, with the best will in the world, I am human too, you do sort of think, oh, you've had them during the good bit, you've had them during the honeymoon period, you've had them during the twiddling about a bit still works, and this is what we now call the slippery slope bit, where we're still twiddling, but it's not working as well. And it is appropriate for geriatricians to be involved in this, because it is very much more about that holistic looking at, what are the issues, what are the problems, what are the support mechanisms, the support services. When is it appropriate to start thinking maybe we shouldn't be aggressively managing this anymore? So I'm not complaining really, but the bit when things work is nice. So he came to Kirsten on Madapar, pergolide and amantadine. Again, these are adjuncts. Amantadine is used to treat Parkinson's disease, but it's more typically used to treat drug-induced dyskinesia. So I don't know whether that was why this particular patient was on it, but it's more typically used for that. And at this point, people are starting to report concerns about his cognition. Of particular concern, driving, a subject very dear to my heart. One of the things I do in Wanganui is I work with Age Concern, who run sessions that are designed to educate people about what's available to them when they have to stop driving, and it's always interesting to talk to people, in the community who never think this is going to happen to them. It happens to everyone else, but it's never going to happen to them, and who think driving is an absolute right, and if I tell them they have to stop driving, I'm the worst person on the planet. And I have had a death threat before now. Alarm bells. When people start to raise concerns about driving in someone where they've maybe not been concerned before, you start thinking, could this be a cognitive issue? Perhaps even more concerning, this guy was out with a gun, and at one point, the police had to call in armed defenders to disarm him, which they then had dealt with and, made arrangements to take the gun away. But it's harder to take someone's car away, it seems. And Kirsten decided to try him with some anti-dementia medication. Were any of you here for the dementia seminar that we had earlier in the year? Yeah. Oh, welcome back. Thank you for coming back again. If you haven't, please do go online and have a look at some of the talks. There were some really good talks that day. Donepezil, when it first came out, everyone got very excited. We thought, at last, there's a treatment for dementia. It's not very good, unfortunately. data series tend to suggest that only about 1 in 15 or 16 people get any real benefit, and it's always temporary. So this guy did improve a bit with donepezil, and then for various reasons Kirsten thought, well, you know, do we start looking at reducing some of these medications, because there's no doubt pergolide in particular can be associated with cognitive adverse effect. And before you label someone as totally having dementia, we do try and look for reversible causes of cognitive change, of course. Again, he had comorbidities. Most of them do. He had osteoarthritis, and at one point the decision was made to offer him a knee replacement. Now, I love my orthopaedic colleagues. They're really good at what they do. Sometimes I question whether they should be doing it, but, you know, I wasn't there, so I don't know whether it was really appropriate this man had knee surgery. What I do know is if you put people with Parkinson's disease and a bit of cognitive issue in hospital, and you operate on them and you anaesthetise them and you give them painkillers, they do tend to get a bit delirious. And that can be quite interesting. The other thing is that... And I don't have an answer for this. I've tried so many different things. They never get their medication on time in hospital. You know, people who've taken their medication for their Parkinson's at home for years, and they know exactly when they take it and when it kicks in and when to have breakfast. And the first thing we do when we bring them into hospital is take away all that control and change the timing of their medications to suit the nursing ward round. And it's one of my pet peeves, and I go around and rant at people and say, give them their medicine when they normally have it. Parkinson's meds, it's less important for some other things, but definitely Parkinson's meds, you need to keep it going when they normally have it. And subsequent to his surgery and his post-op delirium, the decision was made to offer him a period of inpatient rehab. And Kirsten said, interestingly, he raised this point that, you know, he was concerned because his wife didn't want sex as often as he did. I love the comment, I don't often ask about it. I hardly ever ask about it, I'll be honest, I'm a coward. But he'd clearly offered this information, and in front of his wife. So, you know, one might argue, well, he might have always been like that, but is this a bit of disinhibition? Is it really that his wife is wanting sex less, or is he wanting it more because he's becoming more disinhibited? He did get home, supports were put in place, his medication had been tweaked, and then another issue arose where his wife, and again, elderly patients often have elderly spouses with health issues of their own, she sadly died. And his daughters and granddaughters were very supportive and started to assist this guy, and the issue arose that he was making inappropriate sexual overtures to one of his granddaughters and to the caregivers coming in from the agencies. So again, this is one of those, if you like, neuropsychiatric symptoms that can develop as the condition progresses. And as healthcare professionals, we have to be objective and understand that this is the disease. Mostly, I mean, the news is full of sex predators at the moment. You kind of start to feel they are on every corner, but you know, I don't think they are. But, you know, certain diseases will cause disinhibition, and it can be sexual. Has anyone else had patients that are these patients familiar? You know them, you see them? Yeah.
Have you got any fantastic tips on managing it?
Yeah, I'm going to defer to my expert colleague. I think you'll probably cover this in your talk later, or would you care to comment now?
Just one word, paroxetine.
Yeah.
I'll speak more to that later.
Yeah, I'll just chip in and say it's a great example of where we use a treatment for its adverse effect. It's an example of where we use a treatment for an adverse effect. Sexual loss of libido is a side effect of paroxetine. So if you give paroxetine to people with depression, you should warn them that they may do anyway if they're depressed, but it is a side effect. So in this case, we are using a drug not for its antidepressant effects, but for its side effect. We won't tell Mr. J that. Here's another patient. Quite a sad case, I think. Again, one of Kirsten's patients. So this is a lady who's had early onset Parkinson's disease, often more severe, often rapidly progressive, challenging. At this point, she's only in her late 60s. And she's had not just pharmacological treatment, but had insertion of a deep brain stimulator. And I know that David will touch on this later as well. Unfortunately, it was complicated by hemorrhage, and she's been left with what in effect are stroke-like symptoms and signs. So she's wheelchair dependent, she no longer speaks, she is dystonic, she's at home with a loving husband and a package of care, and things have, not been great, but they've been going as well as they could be. And she's also on this combination of Madapar, Pergolide and amantadine. Don't see a lot of Pergolide these days, I must say. I don't know. I haven't had the opportunity to ask my PHARMAC colleagues why they use it so much, or maybe these are 2 of 1 million patients and the others aren't on it, but you don't see a lot of Pergolide. And she was referred to Kirsten because there were concerns that she appeared to be having blank episodes. And the question always arises, is this syncope? Is it postural hypotension? Well, no, it wasn't. And in fact, she didn't change her posture very much. She couldn't stand, so she was seated in the shower much as she was seated in the wheelchair. Showers usually are warm, which does cause some vasodilatation, of course. But interestingly and rightly, and it's one of those things, you don't think of it till you think of it, but Kirsten wondered, could this possibly be seizure activity? And as I'm sure many of you, if not all of you, will know and have seen, not everyone has classic tonic-clonic seizures. Sometimes you don't see the seizure, you only see the post-ictal state. And interestingly, I have a patient on my ward at the moment who is rehabbing from a stroke, and the staff were telling me, sometimes he's really alert and lucid, sometimes he's alert but not lucid, and sometimes he's not alert. And he got better with some anti-epileptic medication. But we never saw a fit. This lady's unfortunately got a pressure sore, which relates to where the battery for the deep brain stimulator was sited. She's got spasticity in the arm that was affected by the hemorrhage. She's had previous Botox. The decision was made to disconnect the deep brain stimulator and remove the battery to try and promote some wound healing. But unfortunately, the wire was still there and caused some difficulties. And Kirsten, in conjunction with the husband and as much as possible the patient, had that difficult conversation that we're all familiar with of, where are we going at this stage? How much do we keep aggressively managing someone who can't tell us if they're suffering but objectively appears to have degrees of suffering? When do we make that decision to start to switch to palliation? And there was a very slow decrease of medication, which was not associated with any detriment. And ultimately, that lady then was effectively palliated, hospice were involved, and had a very peaceful death at home. I think that's a good outcome. Another patient. So this is a lady in her 80s. She lives with her husband. She's had Parkinson's disease for 10 years. And she's done well up to now. And unfortunately, she's presented with a fall. I love the story. She and her husband got tangled and he landed on her. I'd love to know I want to know, were they dancing? Were they, but great story. But, our patients fall. And I see, quite a few patients with falls and fractures and all those other complications thereof. This poor lady had fractured ribs and had a hemopneumothorax and ended up having to be admitted and have a chest drain. And she had some delirium. And again, Kirsten uses donepezil more than I do, I think. Again, she may be right, I may be wrong, I don't know. I've not personally used donepezil as a treatment for delirium, but there are anecdotal reports of it helping with, behavioural symptoms in dementia and delirium, and in this case it did seem to help. But unfortunately, the lady went into urinary retention, which is it's anticholinergic, it's one of the side effects. And ultimately, sadly, this lady ended up not rehabilitating or recovering as well as one would hope, and she ended up in residential care. So just a reminder that, you know, we think of Parkinson's as a sort of inexorable slow decline, but things can happen that precipitate bigger changes. And in this case, you know, a fall has led to an absolutely life-changing incident where a lady's no longer at home living with her husband.
Jan, can I just ask you...
Please do.
About the Madapar, and you talked about the previous case where the lady you reduced to other medications, but she went into palliative care. What sort of... is the time? I mean, are we going to reduce the Madapar as well, or how does that sort of work in palliative care?
I think there's no right and wrong answer, as with all these things. Certainly my experience is if you stop Madapar abruptly, people do get an abrupt withdrawal and they will get a lot worse. Now, if you've concluded that they're at the end of life for some other reason, you know, they've maybe had a massive stroke or their dementia's progressed to a point that they're no longer eating and drinking and they're in, you know, perhaps a nursing home, then you're not going to do a lot of harm by stopping the Madapar for those last few days and doing the sort of usual palliative care anticipatory prescribing that we would do in terms of, you know, morphine for pain or breathlessness and, you know, haloperidol for nausea or distress, the things that end-of-life pathways teach us. If someone's, you know, if you're having those conversations with the person or with the family, if it's appropriate around, you know, maybe they're coming towards the end of their life, but they're not going to die tomorrow, I wouldn't just stop Madapar. I would maybe try and think about reducing it. You know, it's again, you always have to think of what we tend to refer to as the burden of the medication. I have looked after a lady who is beautifully cared for by her husband, does an amazing job. To my way of thinking, and this is not objective, this is me as a human being, her quality of life must be miserable. She's got advanced multiple comorbidities, but she's beautifully cared for. He loves her. We've had the conversation about palliation about 6 times, and he's not ready. And I don't know if he ever will be ready. But where we have sort of moved to is he has agreed that if it ever gets to a point where he can no longer to get her to take her medication without it being a big fight, that he would back off at that point and think, you know, because the burden of those pills is quite significant, and this is a lady who struggles to eat and drink, and, you know, shoveling pills down people is challenging at times, as we all know, and if, you know, if the challenge of doing that outweighs any conceivable benefit they can get from it, then I would stop. So, yeah.
Thanks.
Does anyone else have a comment on that? Do any of you have an interest in palliative care that you would share? Or please speak, people. I can't keep talking. Yes, let's not forget the non-medical treatment options. I'm extremely fortunate to work with a truly amazing multidisciplinary team who often overrule me. You know, I delude myself if I think I'm any sort of leader or boss in the group that I work with. And, you know, they're really good at working with people and producing benefits that I then take credit for by saying I've made some minor tweak in the medication. There are relaxation techniques that can be used to reduce rigidity. There is absolutely no doubt that regular physical exercise is of benefit, not just to the general health, but in terms of progression of the Parkinson's disease and maintenance of independence. And many of you will be aware there's, you know, a wealth of exciting exercise research going on at the moment in older people. My experience tends to be that older people do a lot of sort of gentle aerobic exercise. They do a lot of walking or maybe go swimming. But what really works is resistance training. So we actually need to be encouraging our middler, me, we need to be encouraging people to be doing resistance type training. So, you don't have to spend a fortune on gym equipment or gym membership. There are other ways you can do it. Again, in my local area, Age Concern run classes, which are designed to promote resistance training as well as some aerobic training in older people. That's been a runaway success. We've now got older people who have trained as trainers and have set up other classes, which is just fantastic. And, really keeping active is so important. Physiotherapy, there are, specific targeted physiotherapy that works on strength and balance and reduces falls risk. Certainly utilise those. The occupational therapists, of course, are excellent at helping people to maintain functional independence with personal cares, domestic tasks. That might involve, training, but also some equipment or home adaptation. Dysphonia can be helped by this phenomenon called the Lee Silverman voice treatment. It's quite hard for me to explain because I'm not a speech and language therapist. I have read about it, but, worth having a look on the internet or talk to your friendly local speech therapist if you have someone with dysphonia. That's not to rule out the role of medication. Sometimes you need to time things. As I said before, in hospital we're really good at screwing up the timing of people's medication, and we do have to target therapy around when they're at their best. There's no good the physio going to someone first thing in the morning before they've had their medication and saying, come on, let's go and do this, that and the other. It's got to be timed right.
Can I just ask about sort of later stage Parkinson's exercise? And age residential care, so we've got an old guy who falls over quite a lot. And the standard morning routine is just kind of everybody doing some exercise. And it's kind of hard for them because it takes so long to get there and he can't keep up very well. Is it worth kind of just doing his own routine that somebody helps him with, or is it probably just, too late?
It's never too late. I mean, there is research that has specifically looked at introducing exercise to people who are in, late stage residential care, nursing home level, who are in their 80s and 90s, and they do get some benefit. So it's never too late. How you do it is always a challenge. Yes, there's a role for individualised programmes. That's very person power intensive if it's one-on-one. Group activities certainly have a role. I would say, if someone's struggling to keep up with a group activity, you shouldn't necessarily exclude them from that activity, if they take a bit longer or they're only able to do a proportion of it, because there is a social connection to that. I think that's partly why the Age Concern project locally has taken off so much, because, people are not just getting exercising, they're getting to know each other. And, often there is, the cup of coffee afterwards and the chat. So I don't think there's, I can't say there isn't a right and wrong way to provide exercise, because there is, but, you do need to have some flexibility and try and individualise it for the person. But it is never too late, unless they're actively dying. Hi.
I saw a TV program a while ago which was saying that some Parkinson's people do well cycling.
Mm-hmm.
Is that an individual thing or more of a general thing? And if so, why?
Cycling is predominantly an aerobic exercise. There is obviously a resistance component to it, but it's a relatively low impact exercise. But all exercise is good, provided you're not putting yourself at danger doing it. I'm not familiar with the specific study that you're referring to, so I can't comment in too much detail. But yeah, cycling, if people can cycle, well, exactly. In my inpatient unit, we have a static bicycle as well as a treadmill, and some patients can manage one and not the other. So you tailor the therapy to suit, what they can do. And I think there has to be an element of enjoyment in it as well. You've got to find something that the person will do and continue to do, because, all the research shows benefits of exercise while it's happening. It seems really obvious to say it, doesn't it? But if you don't keep doing it, the benefits aren't maintained. And that's often what happens if people are in a, they're in a lovely research project where they're going, people are making a fuss of them, they're doing everything they're being asked to do, and then it all ends and they go away. Do they keep doing it? Not always. So having a component of enjoyment, I think, is really important. All right. Again, I'm not going to go in great detail now. Please feel free to come and ask me questions if you want to about specific patients. But I have had the privilege of seeing Dr. Bourke's slides, so I know he's going to talk about this. I mainly treat older people, and the mainstay of treatment still remains the L-DOPA. The two commonest things that we use would be Sinemet and Madapar. Essentially, the additional components in the tablets are there to reduce the side effects of the L-DOPA and try and make as much of it get to the brain as possible. If you just have L-DOPA, the side effect profile is horrific. It's very nausea-inducing and it just isn't really tolerated, and not very much of it actually reaches the brain. So it is converted to dopamine by an enzyme called dopa decarboxylase. So some of the adjunct treatments work by affecting the dopa decarboxylase. Even with the carrier mechanisms, if you like, a lot of it doesn't reach the brain. And what it does do is it temporarily reduces more so the motor symptoms of the disease than the other things. And again, many of you, I'm sure, will have come across patients who they can almost tell what their dopamine levels are, and they know when it's wearing off and they know when the next one's due. Side effects, typically nausea, horrific nausea, and it can cause dyskinesia, which tends to be dose related, and some people get a sense of joint stiffness. If people habitually overuse it, they can get this thing called dopamine dysregulation syndrome, where it effectively just stops working, so they get all the side effects and they can't come off it, but it's not really doing much good. Just one thing, who are pharmacists here? Anybody? Yeah. Oh no, they're all cowering. No. Typically, pharmacists tell my patients that they must take their dopamine medication on an empty stomach, and there's no doubt it's better absorbed if you do. However, what I say to patients, and I got this tip from a neurologist, I didn't make this up, is when you first start taking it, take it with food. And the reason is when you first start taking it, if you take it on an empty stomach, you are much, much, much more likely to get the nausea. Whereas if you take it with food, you don't. And so what I generally say to people is when you first start take it with food, and then as and when you can, try and move it away from food, or move the food away from it. But if you just tell people from day one to take it on an empty stomach, they often get really, really dreadful nausea. I'm running out of time. I don't want to keep you from your coffee, but particular issues. So again, Kirsten's wisdom. When things start to decline, when the honeymoon period is over, always start to think what's happening with the cognition here, because that might be what's changing. It might be that the motor symptoms have progressed. And if there are cognitive issues, think about stuff, not amandine, amantadine, or pergolide, and do consider donepezil. It may not work very well for most people. It does work for some people. The only way to know is to try. If it doesn't work, you can always stop it again. Try and simplify medication. So, with cognitive issues, it's much easier to take medicines twice a day than 6 times a day. So if you can, try and simplify things. Just as a caveat to that, though, when you change people's Parkinson's meds, even if all you're doing is making it from short-acting to long-acting, be mindful that things can get worse as well as better, and if they do, change back. Try and change one thing at a time, then you know what is and isn't working. Talk with carers about behavioural symptoms, particularly, these really quite profound ones that can be extremely distressing: compulsive shopping, compulsive gambling, sudden infidelity in people who've, been happily married for decades. then they're probably not going to tell you about those things themselves, so you have to ask the others. And this is a lovely statement, I think. I like the explanation that as you get cell death with PD, you may not need as much medication to have an effect, giving you the opportunity to decrease. So I think, you know, even early on, it's useful to have conversations with people and say, you know, initially what we'll probably find is that we'll be increasing your medication over time, but then due to the nature of the condition itself, after that we may find that we're able to start decreasing it again, so that you forewarn people really. I think it is important, to be honest with people, that it is progressive, it is degenerative, it is neurological, it will get worse. There's nothing harder than creating unrealistic expectations of cure or brilliance. I have a family member with Parkinson's disease whose daughter recently said to me, "I know that Dad won't die of Parkinson's disease." And I had to say to her, he might. But she'd somehow got the idea that this was a condition that people could live with totally indefinitely. And as geriatricians, we do this a lot, and I'm sure as primary care health workers you do it even more, but what we're often doing is managing the problem, not the diagnosis. We're managing the people, we're managing the issues, we're managing the person, you know, the situation, complex social dynamics. And not everything is the Parkinson's. I have a lovely gentleman who comes to see me in clinic who every time he comes to see me has a new symptom and always assumes it's related to his Parkinson's disease, and about 50% of the time it isn't. So it isn't always the Parkinson's. I'm going to shut up. Thank you all very much.
Thank you.